Good afternoon. I'm Deborah Hornacek. I'm from Cleveland Clinic, the section of vascular medicine, and I'm presenting topic today of coagulation disorders, novel anticoagulants, and perioperative management of anticoagulation. I have no relevant disclosures. So an overview of our topics today. So coagulation disorders include hypercoagulable states, thrombophilias, other conditions associated with increased thrombotic risk, including atrial fibrillation and prosthetic heart valves, and then, of course, the novel anticoagulants and perioperative anticoagulation, which includes parenteral anticoagulants, warfarin, direct oral anticoagulants. Coagulation disorders. So this is a rather broad topic to cover within the span of an hour talk, but we're going to briefly review warning symptoms and diagnosis of acute DVT and PE, acquired hypercoagulable states, those thrombophilias as previously mentioned, and again, those other conditions. So why is this relevant? So venous thromboembolism is the third most common cause of hospital-related death in the United States. Interestingly, only about a third of all hospitalized patients actually receive appropriate prophylactic treatment for VTE, and 2/3 of all VTE events are related to hospitalization. PE is actually the third leading cause of cardiovascular death, as per the American Heart Association 2016 statistics. That big orange category that says other at 16.9%, the vast majority of those cases actually are pulmonary embolism. Interestingly, data has shown that the incidence rate of MI and stroke have actually downtrended and plateaued. However, the incident rate of venous thromboembolism has continued to increase over time. So just a quick reminder about acute pulmonary embolism, clinical presentation. So classic symptoms are sudden shortness of breath, chest pain, loss of consciousness or pre-syncope, and hemoptysis. However, 70% of symptomatic PE patients do have concomitant DVT, so it's important to always scan at least the lower extremities. As a quick management pearl about this, more hospitals are developing what we call pulmonary embolism response teams, or PERT teams, to help with the clinical decision-making for patients who have high risk of PE, including massive or submassive PE, and also high bleeding risk. So ask at your hospital if this service is available. For acute DVT clinical presentation, classic symptoms include lower extremity redness, swelling, plethora or congested appearance, tenderness, and sometimes visible collateral superficial veins. About 1/3 of symptomatic DVT patients will have a PE, but it's actually been open to debate about whether you really need to go looking for pulmonary embolism if the patient is asymptomatic from standpoint of PE. Will it actually change your clinical management? Surgical patients always have a high pretest probability for DVT if they are symptomatic. So the Wells criteria was actually a criterion developed by Dr. Phil Wells and validated as a way to stratify outpatients as likely or unlikely to have lower extremity DVT based on their presenting history and exam features. So if you quickly review this list of features from the Wells score, you will immediately recognize how many of your post-surgical patients are automatically placed in the moderate to high-risk group based on this listed criteria. It's been noted that the Wells score is less useful in hospitalized patients. Again, many of those patients quickly fall into the higher risk groups, and testing with a high-sensitivity D-dimer test can be positive due to causes other than venous thromboembolism, which means these patients will default to needing an ultrasound. The role of D-dimer is something that's often not well understood. So clinical prediction rules in of themselves cannot safely exclude PE or DVT and have to be used in conjunction with D-dimer testing. There are several other clinical prediction rules as well, which I did not list. There's the Wells score for PE, the Geneva score, the Miniati score, and many others. These all have comparable accuracy, but again, must be used with D-dimer testing. Patients are with an unlikely venous thromboembolism based on one of those clinical decision rules, such as the Geneva score or the Wells score. This diagnosis can effectively be excluded by presence of a normal D-dimer. But in translation, this means only low-risk patients can rule out using D-dimer. A good example of this is the fact that high probability patients with a negative D-dimer may still have upwards of a 15% incidence of pulmonary embolism on imaging. There's also lower specificity of these clinical decision rules and D-dimer in patients with cancer and hospitalized patients. And just a quick note about the D-dimer. What actually is it? So reaching all the way back to med school, D-dimer is a fibrin degradation product, and there are several known factors associated with positive results. There are increasing studies that actually suggest an age-adjusted D-dimer threshold could be calculated by multiplying a patient's age by 10, meaning a so-called normal D-dimer for a 70-year-old might be 700 instead of the lab-defined normal range of 500. This concept has not been fully implemented in practice, so I would caution against disregarding elevated D-dimer labs without adequately ruling out thrombosis or reviewing with an expert. Additional factors associated with positive results include female gender or African American ethnicity, medical history-related factors including connective tissue disorders such as rheumatoid arthritis or lupus, being on hemodialysis, malignancy, pregnancy, and sickle cell disease. Recent surgery and prolonged immobility can also be associated with elevations in D-dimer. And ultimately, the best reason to really go looking for a cause of your patient's symptoms, if they do have that chest pain or leg swelling, is to make sure that you're not missing another DVT or PE mimic. So I always advise to have a low threshold for imaging when suspecting venous thromboembolism in a post-surgical patient. So this is an example from a patient with a positive D-dimer who on an ultrasound was found to have a 24-centimeter long hematoma in the right popliteal fossa. Hematoma is absolutely one of those complications you do not want to miss, particularly due to risk of expansion compartment syndrome if empiric anticoagulation were to be started based only on clinical exam. So on to our coagulation disorders. So coagulation disorders can be grouped into three major groups: situational, inherited, and acquired. Situational prothrombotic states represent a temporary state of hypercoagulability. Inherited hypercoagulability is an underlying genetic prothrombotic tendency. Acquired coagulation disorders are hypercoagulable states related to an underlying medical condition. So some examples for us. Situational risk factors include, as we've alluded to, surgery, prolonged immobility, trauma, chemotherapy, immunotherapies, and antiretroviral therapies, hormonal therapies, most notably oral contraceptives and hormone replacement therapy, but now also extending to testosterone replacement therapy, pregnancy, obesity, placement of central venous catheters, and heparin-induced thrombocytopenia. Inherited coagulable factors include the hereditary thrombophilias, including factor V Leiden, prothrombin gene mutation, the natural anticoagulant deficiencies, including protein C, protein S, and antithrombin deficiencies. Other point mutations in the factor V and prothrombin gene mutations, which are typically less common, JAK2 mutation, and dysfibrinogenemia, which can actually be inherited or acquired and can be associated both with bleeding or thrombosis. So interestingly, the most frequent causes of inherited hypercoagulable states are the factor V Leiden mutation and the prothrombin gene mutation. These together account for 50 to 60% of cases. Defects in protein C, protein S, and antithrombin, which is formerly referred to as antithrombin 3, account for most of the remaining cases. Only a very small percent of cases consist of other rare inherited thrombophilias. The thrombotic risk associated with each of the inherited thrombophilias has been assessed in two ways over many years of studies: evaluation of patients with DVT and evaluation of families with known thrombophilias. The last category is of acquired coagulation risk factors, or medical risk factors. These include factors such as cancer, acquired thrombophilias, such as antiphospholipid antibodies, factor VIII elevation, hyperhomocystinemia, systemic inflammatory conditions, such as vasculitis, lupus, rheumatoid arthritis, or inflammatory bowel disease, nephrotic syndrome, myeloproliferative syndrome, hyperviscosity syndromes, PNH, and then systemic infections such as HIV, hepatitis, and other severe infections. A note about nephrotic syndrome: the heavy proteinuria in this syndrome actually results in loss into the urine of protein C, protein S, and antithrombin. So some additional notes about venous thromboembolic risk in patients with cancer, because we're seeing more of these patients and they're living longer and undergoing more procedures. So upwards of 15% of patients with cancer will present at some point in time with a symptomatic venous thromboembolic event. Their post-op risk is actually upwards of 36% with a relative risk of 2 to 5. And interestingly, VTE prevalence on autopsies ranges from 20 to 50%. Now, VTE incidence is highly variable depending on malignancy type. So this ranges from a somewhat lower risk associated with head and neck cancers at a rate of 16 DVT and PE per 10,000 patients, up to very high risks of 110 to 120 DVT and PE per 10,000 patients for those patients dealing with pancreatic, brain, and ovarian cancer. You can see this wide range of malignancies and presentations as listed here. Additionally, there have been studies that have compared the risk in these patients with cancer versus other patients at different stages of treatment or in patients who do not have diagnosis of cancer. So, for example, all cancers combined versus a patient without cancer, the relative risk over 5 years is approaching 7-fold increased risk. Cancer within the first 3 months of diagnosis carries some of the highest risk at a 53 relative risk. Cancer with metastatic burden versus a patient without cancer is a 58 increase in relative risk. And cancer with metastasis versus no presence of metastasis is an almost 20% increase in relative risk. There's been attempts at ranking these different hypercoagulable states in terms of severity. So to take an average patient who's hospitalized without malignancy, and in this case, a medical patient not undergoing any type of surgery, their risk of thrombosis would be estimated as your kind of standard at 1. If you were to add hormone replacement therapy or pregnancy or a prothrombin gene mutation, and specifically heterozygosity for a prothrombin gene mutation, that's a multiplier of 3. If this patient were instead to have breast cancer or factor V Leiden heterozygosity, their risk of thrombosis would be a 4 or a 5 increase. You can subsequently see that antiphospholipid antibodies, vasculitis, HIT, lung cancer, breast cancer on active treatment, and then the pancreatic and GI adenocarcinoma malignancies are all associated with escalating risk of thrombosis. Another phenomenon that's often overlooked is the fact that there's increasing risk of thrombosis just by the process of aging. There's actually a 100-fold increase in risk for venous thromboembolism when comparing a 20-year-old patient to a 50-year-old patient, even when controlling for all other variables. An additional factor that can be hard to quantify is the risk associated with prior VTE. However, there's increasing recognition that patients with prior VTE remain at increased risk for additional events even decades beyond their initial DVT or PE and have increased mortality related to VTE. There's now data from a 30-year nationwide population-based cohort study of over 128,000 patients with first-time venous thromboembolism compared to 640,000 patients from the general population without VTE. These patients are at increased risk of dying, especially within the first year after diagnosis, but also during the subsequent decades of follow-up. This remains an important cause of their death. Interestingly, 30-day mortality has remained fairly constant for DVT over the last 30 years. However, it has improved somewhat for PE. For surgical patients, the risk of postoperative VTE should be estimated prior to undergoing surgery, and the patient should be stratified into very low, low, moderate, or high risk so that an appropriate method of thromboembolic prophylaxis can be planned. The American College of Chest Physicians, or ACCP, provides general estimates of baseline risk for VTE based on surgical type. However, the specific risk of VTE associated with individual surgeries is highly variable, reflecting the wide range of surgeries within each specialty. And ultimately, venous thromboembolic risk depends on two major factors: procedure-related factors, including the duration and extent of surgery, the anticipated post-operative mobility, or rather immobility, and the type of anesthesia, among other factors. And the second category is patient-related factors, which includes the situational, inherited, and acquired risk factors as previously outlined. Although there's been many attempts to find a method to quantify VTE risk, no one method has been found to fit all surgical scenarios, and many physicians use an estimate based on their own clinical expertise and the general VTE rates provided by the ACCP. Alternatively, you can use a thrombosis risk model such as the Caprini score or the modified Caprini score to make a more specific determination. The modified Caprini score characteristics are shown here with the interpretation on the following slide. The modified score was developed for use with the 2012 ACCP guidelines regarding perioperative venous thromboembolic prevention, and it was simplified from the original score's format. However, you can see looking at this chart that this is rather cumbersome to use when trying to apply to each and every patient. However, it forms an excellent background or an excellent reference. The caveat of the modified Caprini model is that it has been validated in patients undergoing general surgeries, including breast, thyroid, parathyroid, and abdominal pelvic surgery, including gastrointestinal, urologic, and gynecologic. It does include those who are critically ill. Although not validated in other surgical populations, it is considered by most experts to be acceptable for estimation of risk for patients undergoing bariatric and vascular surgery. The risk model did undergo further modification for patients undergoing plastic and reconstructive surgery, since the validation study actually reported a lower risk of VTE for any given Caprini score in that population. The original Caprini score was developed in 1991 by Dr. Caprini and his colleagues, who studied 538 patients admitted for surgeries. They weighed 20 different risk factors that were obtained from face-to-face history, and a total risk score was obtained for each patient. Patients were stratified then into a low, moderate, and high-risk group depending on their scores. The risk model has been validated, as previously mentioned, in many different settings. Patients with higher Caprini scores are significantly more likely to have VTE, and those with Caprini scores of greater than 7 have the most significant reduction of VTE risk when chemoprophylaxis, or rather mini-dose anticoagulation, is used after surgery. Several studies have suggested and validated different strategies of VTE prophylaxis. One of those strategies is included in this table here. Due to containing the 20 specific risk factors, this risk model, again, is rather cumbersome to use, but it is very patient-specific and very situation-specific. I think the main benefit of referencing the Caprini or modified Caprini score for any patient is when you're trying to decide whether your high-risk patient may benefit from extending duration of prophylaxis beyond their immediate hospitalization. In general, patients at the highest risk for VTE are going to be the patients that you recognize as being high risk, undergoing major surgeries, having malignancy, and then having prolonged immobility afterwards. Those highest risk surgeries generally include major orthopedic surgeries, major vascular surgeries, or this category often pulled from the literature of just quote-unquote major surgery. So major orthopedic surgeries include large joint surgeries such as hip or knee arthroplasty. There's an estimated risk of asymptomatic VTE in greater than 50% of patients if they're not administered prophylaxis, and an estimated asymptomatic VTE rate of approximately 12 to 18% with pharmacologic prophylaxis. This does include calf DVTs, which have been of debatable clinical significance. Symptomatic VTE risk is less than 5%, particularly in the setting of prophylaxis, and fatal PE becomes 0.5 to 0.8%. Spinal cord injury, however, is a major modifier of this risk. So of patients with spinal cord injury, approximately 38% are going to end up developing an acute DVT, typically in the lower extremity, within 3 months of onset of the paralysis. Approximately 5% are going to have acute pulmonary embolism, and risk is greatest during the first 2 weeks after paralysis. Patients undergoing major vascular surgery are also at increased risk for thrombotic complications. There's an approximate all DVT risk rate of 15 to 25% without prophylaxis. All DVT and proximal DVT specifically with prophylaxis drops to about 10% and 6% respectively. Symptomatic VTE within 3 months of major vascular surgery is estimated to be 1.7 to 2.8% in population-based studies, and symptomatic DVT occurs in about 0.9% of lower extremity bypass and AAA repair surgeries. The last groups that are frequently reported in literature, and there's often specific professional society data and publications about this, are the so-called major surgeries. And this, like I said before, tends to be kind of a bucket term. So generally in this category in the literature, there's included abdominal, pelvic, or thoracic surgeries that require general anesthesia for more than 30 minutes. This also includes CABG, surgeries for gynecologic malignancies, and major urologic surgery, and neurosurgery. Unfortunately, there's not great prospective control data on the incidence of VTE with endoscopic procedures, and there's also a paucity of data for arthroscopic procedures. Other considerations, aside from just being bedbound, specifically cast immobilization after tibial or other fracture is also highly associated with increased risk of thrombosis. So plaster casting, if you'll recall from the Wells score, was noted as a significant risk factor. So approximately 45% of patients without VTE prophylaxis will develop an acute DVT. Interestingly, about 1/3 of these will be symptomatic, and many of these may very well end up being less clinically significant calf DVT. Polytrauma, again, carries very high risk for DVT. Overall DVT rates approach 47%, which includes a proximal leg DVT rate of 12%. And then from a breakdown perspective, the rate of DVT is 56% if the primary site of injury was the lower limbs or pelvis, and drops slightly to 40% if the primary site of injury was face, chest, and abdomen. So have a high clinical degree of suspicion for DVT in these patients. So a summary with some risk comparison of these different risk factors is given here. So this is an attempt to kind of stratify the lower risk patients, the moderate risk patients, and the highest risk patients. Please note that the highest risk patients have an odds ratio of greater than 10 for development of DVT or PE. Those patients include those undergoing major surgery, again, that bucket term, hip and knee replacement or a fracture, polytrauma, spinal cord injury, those who have antiphospholipid antibody syndrome, including lupus anticoagulant, antithrombin deficiency, and advanced stages of malignancy. So what can we do about the risk of DVT and PE associated with surgery, particularly for our patients with other hypercoagulability risk factors? Well, as we previously alluded to with the Caprini score, the impact of thromboprophylaxis has been confirmed in numerous studies. The PADRO prediction score is another risk assessment model. Their data included over 1,100 patients who were stratified to high versus low risk for VTE. The study served to validate the risk prediction score and also to show reduction of VTE risk when adequate prophylaxis was used. And in this case, adequate prophylaxis referred to unfractionated heparin 5,000 units 3 times a day, enoxaparin 40 milligrams daily, or other equivalent low-dose anticoagulation in their study started within 48 hours of hospital admission. In high-risk patients without prophylaxis, 11% sustained VTE as compared to 2% with prophylaxis. VTE occurred in only 0.3% of the low-risk patients they stratified. And most notably, adequate prophylaxis helps to close the gap between high and low-risk patients in terms of their VTE risk. So other high-risk patients to be aware of would be those with atrial fibrillation and those with mechanical prosthetic heart valves. So a quick review. Atrial fibrillation is the uncoordinated electrical activation of the atria, leading to ineffective contraction with resultant stasis of blood and increased risk of thrombus formation, most typically in the left atrial appendage, the left atria, but large thrombus can certainly extend all the way into the left ventricle. There's risk for arterial thromboembolism and stroke. In those patients with non-valvular AFib or NVAF, there's a 5-fold increase in stroke risk. For those patients with AFib in the presence of significant mitral stenosis, there can be upwards of a 20-fold increase in stroke risk. More data is actually available for risk stratification for atrial fibrillation as compared to venous thromboembolism. However, the majority of data has been validated in non-procedural and non-perioperative settings. The 2014 American Heart Association, American College of Cardiology, and Heart Rhythm Society guidelines recommend use of the CHA2DS2-VASc score for risk stratification. From this guideline, patients with a score of greater than or equal than 2 benefit from anticoagulation to help reduce their risk of stroke or peripheral embolization. However, again, the score is validated in the non-perioperative setting. So just as an example, so these would be the patient characteristics that are contained in the CHA2DS2-VASc score. You can see that each of these different factors earns a patient 2 points, except for age, greater than 75, which warrants 2 points, and stroke or a TIA history, which also earns them 2 points. Everything else earns 1 point. These are added up together with a total possible score of up to 9. This correlates with an estimated annual stroke risk off anticoagulation. For a patient without any risk factors, their score is 0, and their annual estimated risk approaches 0. Risk subsequently increases with increasing risk factors as expected, and can be as high as 10 to 15% as per some reported data. For those patients with atrial fibrillation with high thrombotic risk, these are their patients that are out there with equal to or greater than 7 points on their CHA2DS2-VASc score, or they've had a recent stroke or TIA within the prior 3 months, or they have a history of rheumatic valvular heart disease. Their risk of stroke or arterial embolization is 10% per year if off anticoagulation. And in the setting of surgery, they have the additional transient thrombotic risk associated with the surgery itself in the postoperative period. Management of these patients in the perioperative period has been under some controversy lately due to data from a trial called the Bridge trial. However, expert consensus and current guidelines recommend bridging anticoagulation in these patients who have a CHA2DS2-VASc score of equal to or greater than 7. As a quick summary, the Bridge trial was a trial that was just done in 2015. The study design was randomized, double-blind, placebo-controlled, and it looked at 1,800 patients on warfarin for atrial fibrillation. These were all patients who were undergoing elective procedures. These included cardiothoracic, gastrointestinal, and orthopedic surgeries, which required cessation of anticoagulation therapy. All patients followed the same protocol of stopping warfarin 5 days before the procedure, and all resumed warfarin on post-op day number 1. The groups were randomized to therapeutic dosed dalteparin, which is a low molecular weight heparin, or a placebo agent. The placebo or dalteparin were started 3 days before surgery and stopped 24 hours before the procedure, as per usual bridging protocol. The parenteral anticoagulant of dalteparin or placebo was resumed 12 to 24 hours after a minor procedure or 48 to 72 hours after a major procedure. These were continued for 5 to 10 days until the INR was greater than 2. The final results of the Bridge trial yielded the comments that the strategy of discontinuing warfarin without a bridging anticoagulant was non-inferior to the use of bridging anticoagulation in terms of 30-day risk for stroke or TIA or systemic peripheral embolization after surgery. And overall, the event rates were very low in each of the groups. There was arterial embolic events in 0.3% of individuals in the bridging cohort versus 0.4% of individuals in the control group. It was noted that bleeding was increased in the bridged cohort who was on dalteparin therapy, which would be expected. However, there's been many limitations noted in regards to the Bridge trial data. So the mean CHA2DS2-VASc score was 2.3. There was very few patients who were the higher risk patients with a CHA2DS2-VASc score of 5 or 6 or greater. And additionally, there were no patients included who were undergoing major surgical procedures which were associated with high rates of arterial thromboembolism and bleeding, including carotid endarterectomy, major cancer surgeries, cardiac surgery, or neurosurgery. These were all not represented in the trial. An additional limitation is that patients with mechanical heart valves were not included in the trial, and this is known to be a very high-risk group. So moving down the line here somewhat. So patients who have moderate thrombotic risk from their atrial fibrillation, these are those individuals with a CHA2DS2-VASc score of 5 to 6. Their risk of stroke or arterial embolization is about 5 to 10% per year off anticoagulation, and they also have additional transient thrombotic risk during the postoperative period. These are the patients that can be very difficult to determine whether or not to bridge. Generally, expert opinion has supported these decision-making guidelines here. So for patients with increased risk of bleeding, it's recommended that patients avoid bridging. If it is felt that the patient does not have significant increased risk for bleeding, then bridging can be considered. It is recommended to strongly consider bridging in patients with prior stroke, TIA, or other peripheral embolic event. And as always, please consult expert opinion if there's any questions. For those patients with atrial fibrillation who have a low thrombotic risk, they generally have CHA2DS2-VASc score of less than or equal to 4, and their estimated risk of stroke or arterial embolism is less than 5% per year if off anticoagulation. Again, please note, though, that these patients are at increased risk compared to other patients who do not have atrial fibrillation, and they too have additional transient prothrombotic risk during the perioperative time period. The low-risk patients were actually very well represented in the bridge trial, and as a result, expert consensus recommends no bridging in this group. It is recommended to resume anticoagulation as soon as feasible after surgery, and so long as the patient is tolerating PO intake, often warfarin can be started on postoperative day number 1. And again, although lower risk than other patients with atrial fibrillation, the risk of stroke and arterial thromboembolism while off anticoagulation should still be reviewed with the patient preoperatively. Another key group to review are those patients who have mechanical heart valves and as a result are at increased thrombotic risk. It is felt that mechanical heart valves are thrombogenic due to turbulent valve flow and shear stress, which in turn increases platelet activation and also thrombin generation. There's an estimated 1.8 to 5.2% annual rate of valve thrombosis if off anticoagulation for these patients. This data is highly variable and depends on the type of valve and other patient risk factors. There's also an estimated 4% annual rate of stroke, peripheral arterial event, and death annually if off anticoagulation for that year. Now, these patients are largely risk stratified based off of the type of valve and the presence of other thrombotic risk factors. You can see in this chart as shown that those patients who are deemed high risk include those who have a prosthetic mitral valve, a cage and ball valve, an aortic tilting disc valve, or a thrombotic event within the past 6 months. Those patients who are moderate risk are those who have a bileaflet aortic valve and one or more thrombotic risk factors, which include atrial fibrillation, stroke or TIA, hypertension, diabetes, heart failure, and age equal to or greater than 75. Those patients who are deemed low risk are those with a bileaflet aortic valve and no thrombotic risk factors. Patients with moderate to high risk should always be bridged with short-term parenteral anticoagulation, either unfractionated heparin IV or injectable low molecular weight heparins. Low-risk patients do not need bridging routinely. But again, please seek expert consultation when needed, and especially in cases with patients who have multiple valve replacements or other valve repairs. There's currently other trials that are underway regarding bridging, and there are new valve models becoming available quite frequently. So if any questions arise, please check with the patient's cardiologist or surgeon. Now for our review of novel anticoagulants. So briefly, the scope of anticoagulation use is huge. So there's more than 2 million patients in North America who are currently treated with oral anticoagulation. Approximately 250,000 patients will undergo a surgical or invasive procedure each year of those patients who are on anticoagulation. And it's estimated that 1 in 10 patients on warfarin will need a surgical procedure. Many patients on anticoagulation are also on antiplatelet agents, which further complicates matters. For all patients, but especially those on combination anticoagulation antiplatelet therapy, it's important to determine a plan that will place them at lowest risk of bleeding while at the same time maintaining a low risk of thromboembolic event. Overall, use of oral anticoagulation is increasing. So this is a chart that looks at the quarterly use of oral anticoagulation during office visits for atrial fibrillation from 2009 to 2014. Each of the different colored lines represents a different anticoagulant. So the green diamond line actually represents warfarin, which has had a slight decrease in use. But you can see the thick blue line at the top is overall rising, and that represents all anticoagulation. This correlates with the introduction of the new direct oral acting anticoagulants. These were started to be introduced into clinical practice in 2010, and despite their cost, these agents have achieved huge popularity among patients and providers due to their efficacy, ease of use, and overall favorable safety profile. As such, they're now often the first-line therapy for stroke prophylaxis in the context of atrial fibrillation, as well as the treatment and prevention of venous thromboembolism. So a quick slide about nomenclature. The category of these new oral anticoagulants go by many class names. For example, NOAC, TSOAC for target-specific oral anticoagulant, and DOAC for direct oral acting anticoagulant. I generally discourage the use of the phrase NOAC, or novel oral anticoagulant, or non-vitamin K oral anticoagulant, because the abbreviation NOAC, N-O-A-C, has been associated with medical errors when written into charts. An unfamiliar person can certainly read N-O-A-C and take this to mean no anticoagulation. So for the purposes of the rest of this talk, I will use the name DOAC when referring to this class of medication. So as I previously alluded, the main increasing use of anticoagulation comes from the increased use of DOACs and the introduction of these agents, and because of their major convenience factors. Warfarin is perceived as being high maintenance. Patients have to monitor their vitamin K intake in their diet. There's a narrow therapeutic index, and this requires lab monitoring of the INR. There's drug and food interactions with the metabolism of warfarin, and there's delayed onset of anticoagulation effect, as well as delayed offset of effect when it's stopped. DOACs are relatively predictable. They're not impacted by intake of vitamin K. There's more consistent pharmacodynamics. There's fewer drug interactions, but there still are some. There's relatively quick onset of action, hours instead of days. Most do not require a heparin product initially for treatment of venous thromboembolism. However, there's many misconceptions about DOACs. Often in practice, these are assumed to be similar to warfarin or low molecular weight heparins, and they're not. They absolutely cannot be used in the setting of mechanical heart valves. There are still some key drug interactions, particularly those medications that increase the metabolism of DOACs and thus result in subtherapeutic anticoagulation concentrations. Procedural interruptions are managed differently. Bleeding management is managed differently. The costs are much more significant, and there is absolutely no bridging when it comes to DOACs. This still seems to be a common point of disbelief. And ultimately, the key to safe and effective use is patient selection, education, and periodic monitoring of metabolic panels and blood counts for patients on DOACs long term. So a quick review of the warfarin mechanism of action. So until the introduction of DOACs, warfarin was the only oral anticoagulant available. Warfarin is a vitamin K antagonist that requires regular blood tests for monitoring of the INR. Vitamin K is required for the carboxylation of clotting proteins 2, 7, 9, and 10. And vitamin K itself is actually a group of chemically similar vitamins, K1, K2, K3, which are fat-soluble and found largely in green vegetables. Without adequate levels of vitamin K, the liver produces partially carboxylated and decarboxylated clotting proteins, which have reduced procoagulant activity. Warfarin interferes with vitamin K-dependent production of these clotting proteins. Warfarin also decreases protein S levels, which transiently increases a prothrombotic state when the medication is first started. In most patients, this is not clinically significant, except for those who have a significant heritable thrombophilia, such as protein C, protein S, or antithrombin deficiency, or the antiphospholipid antibody syndrome. Compared to the vitamin K antagonistic pathway, which involves reduction in activity of factor 9, factor 10, factor 7, and factor 2, the DOACs each act directly on a single coagulation factor, factor 10A. Rivaroxaban, apixaban, and edoxaban all decrease the activity of factor 10A. Dabigatran is the only oral factor 2A or thrombin inhibitor. Through interaction with different points in the coagulation cascade, all of the oral anticoagulants reduce thrombin-stimulated fibrin clot formation. So dabigatran was the first of the DOACs to appear on the market. And a quick note about renal function assessment for all patients on DOAC. This should be calculated using a creatinine clearance via the Krakow-Gault equation. Pradaxa is, as I mentioned previously, an oral direct thrombin inhibitor. Its indications include stroke prevention, atrial fibrillation, treatment of DVT and PE. The key thing with this for venous thromboembolism and Pradaxa is that these patients first need lead-in therapy with a parenteral anticoagulant for 5 to 10 days. This is not bridging. These patients are not on the Pradaxa or the dabigatran at the same time as they're on the parenteral anticoagulant. They're actually only on the unfractionated heparin or the low molecular weight heparin first, and then that is subsequently stopped at the same time as the dabigatran is started. Additional indications for this include long-term prevention of recurrent DVT and PE in patients who've previously been initially treated for their event. There are different dosing schemes, and specifically the key thing to note is that the difference between the atrial fibrillation and the DVT PE dosing is that there is a dose reduction for patients who have renal impairment for the atrial fibrillation dosing, but this same dose reduction does not carry over to those patients taking dabigatran for DVT and PE. The standard dose for DVT and PE is always 150 milligrams twice a day. As I previously alluded, dabigatran and the other DOACs have very rapid onset of action, and dabigatran actually reaches its peak level in 1 to 3 hours. Its half-life is dependent on renal clearance, so it can be as short as 14 hours for a person who has a creatinine clearance greater than 80, or for creatinine clearance less than 15, it can be prolonged to greater than 34 hours. And this medication is contraindicated in patients with a creatinine clearance less than 30. The metabolism of this drug is hepatic, but also largely renal. And exposure to dabigatran directly increases with degree of renal impairment. So area under the curve respectively increases from 1.5-fold to 3.2-fold to 6.3-fold in those patients who have a creatinine clearance of 15 to 30. Other important notes. Do not ever open or crush these capsules, as this will result in a 75% increase in absorption. And this is the only DOAC that can be successfully removed during hemodialysis with specific membranes, and that's because of this drug being so reliant on renal excretion. There is a reversal agent called idarucizumab that is a monoclonal antibody specific to dabigatran. It will not work for other anticoagulants. The next DOAC is rivaroxaban, or Xarelto. This is one of the oral direct factor 10A inhibitors. Its indications include stroke prevention, treatment of DVT and PE, and prevention of DVT and PE following knee or hip replacement. Again, there are some variable dosing schemes here. So for atrial fibrillation, the standard dosing is 20 milligrams once a day. However, there is some data that suggests reduced dosing of 15 milligrams once a day for those patients with renal impairment and a creatinine clearance of 15 to 50. However, there's a relative lack of data of use of this drug in patients with a creatinine clearance less than 30, so the FDA overall recommends avoiding this population. For DVT and PE, initial dosing is 15 milligrams twice a day for 21 days, then followed by a maintenance dose of 20 milligrams once a day. The hip and knee replacement VTE prophylaxis dosing is 10 milligrams once a day. Peak onset of this medication after oral administration is after 2 to 4 hours, and the half-life again varies. However, this tends to be a little bit more stable than dabigatran. Estimates report a half-life of anywhere from 5 to 9 hours. Most data reports the half-life being around 8 to 9 hours. Metabolism, again, is a combination of hepatic and renal excretion. Other important notes: rivaroxaban must be taken with food to improve its bioavailability, and rivaroxaban exposure is increased 44% in mild renal impairment, so creatinine clearance in the 50 to 79 millimeter per minute range, and 52% in moderate renal impairment. The next DOAC is apixaban or Eliquis. Again, this is an oral direct factor Xa inhibitor. This largely has the same indications as rivaroxaban. Again, stroke prevention, treatment of DVT, and then prevention of DVT and PE following knee or hip replacement. Apixaban has the additional indication of the specific line of long-term prevention of DVT or PE after the initial 6 months of therapy with a reduced dosing strategy that generally I would defer that to use by experts. So dosing for atrial fibrillation is 5 milligrams twice a day or 2.5 milligrams twice a day in select patients who have 2 out of the 3 factors present of being either age 80 or greater, being 60 kilos or less, or having a creatinine of 1.5 or greater. Again, patients who have 2 of those 3 factors are dose reduced. For patients who have DVT or PE indication, there is no dose reduction for acute treatment of venous thromboembolism, regardless of the patient characteristics. And this is where patient selection becomes very important when determining which anticoagulant to use on a patient. The initial therapy is 10 milligrams twice a day for 1 week, followed then by 5 milligrams twice a day. That long-term VTE secondary prophylaxis dose is a 2.5 milligram twice a day dose, which is only used after the initial 6 months of therapeutic anticoagulation. And again, I would defer that to expert management. And the knee and hip replacement dosing is also the 2.5 milligram twice a day. Again, this medication has very rapid onset of action, reaching its peak in 3 to 4 hours. Its half-life is estimated to be about 15 to 17 hours, and the metabolism is hepatic and renal, although the renal clearance is less than other DOACs. Overall, there's been some controversy lately about use of apixaban in patients with severe CKD or end-stage renal disease. Currently, consensus statements from American Heart Association, American College of Cardiology, and the Heart Rhythm Society as of January 2014 still state that warfarin remains the anticoagulant of choice for patients with severe renal disease or end-stage renal disease. And one other side note is that apixaban tablets can be crushed to be administered through a feeding tube if need be. Edoxaban is the last of the oral anticoagulants. This, again, is a direct factor Xa inhibitor. This carries indications of stroke prevention, atrial fibrillation, and also treatment of DVT and PE. The dosing scheme for edoxaban or Saveza is a little bit unique in that patients actually must have renal function below a certain threshold to be a candidate for this drug due to risk of increased events if the creatinine clearance is actually too high. So if creatinine clearance is greater than 95 milliliters per minute, then this drug is actually contraindicated for use of atrial fibrillation in these patients. So if creatinine clearance is in the 50 to 95 range, they are placed on 60 milligrams once a day. If the creatinine clearance is 15 to 50 milliliters per minute, they are on 30 milligrams once a day. For DVT or PE, the dosing is 60 milligrams once a day after an initial 5 to 10 days of parenteral anticoagulant therapy. So again, similar to dabigatran, where they have this lead-in therapy. Not bridging, you're not overlapping the two anticoagulants. It really is only the parenteral anticoagulant first, either unfractionated heparin or low molecular weight heparin, then followed by the initiation of the edoxaban. After that initial 5 to 10 days of parenteral anticoagulant, the patient will be on 30 milligrams once a day if their creatinine clearance is 15 to 50, or if the patient weight is less than 60, or if they're taking other medications that have significant interactions. Again, peak onset is in 1 to 2 hours, and creatinine clearance is generally reported to be 10 to 14 hours. Half-life is generally reported to be 10 to 14 hours, even across a range of creatinine clearance. The metabolism of edoxaban is a mix of hepatic and renal clearance, and again, these tablets can be crushed if needed. So some pearls about use of DOACs. So routine coagulation testing is not required or necessary for DOACs. There's variable impact on the APTT and the PT-INR, and this does not correlate to therapeutic effect. Additionally, there are assays available to measure drug levels, but again, these do not correlate well to therapeutic effect. Due to the rapid onset of action, as you could see, peak level was reached anywhere from 1 to 4 hours after administration. Bridging is not indicated. And to clarify again, lead-in parenteral anticoagulation for dabigatran and edoxaban is not bridging. You're not actually overlapping your agents. None of the DOACs are approved for use in pregnant or breastfeeding patients. None of the DOACs are approved for use with mechanical heart valves. And actually, dabigatran was associated with increased risk of severe complications and death in patients who had mechanical heart valves. Avoid use in severe chronic kidney disease and acute renal impairment. And additionally, the International Society on Thrombosis and Hemostasis guidelines suggest avoiding the use of DOACs in patients with a BMI of greater than 40 or weight greater than 120 kilos due to a relative lack of clinical data from the studies for this population. Additionally, there's a few GI considerations to be aware of. So patients who have a history of gastric bypass, short gut, or other malabsorption syndromes may have impaired absorption of oral anticoagulants. It's suggested to consider use of parenteral anticoagulation to bypass GI absorption or to actually use warfarin so that therapeutic can be monitored using INR. You can essentially see is the drug being absorbed because the INR should start going up. Caution should be taken with warfarin dosing in these patients, however, due to the frequency of vitamin K deficiency, given that it's a fat-soluble vitamin, and tendency for patients to have more labile INR or more sensitivity to warfarin. Additionally, while discussing DOACs, please note that these all have a U.S. boxed warning in them in regards to neuroaxial anesthesia. So patients who are on these agents and additionally on enoxaparin, dalteparin, or fondaparin may have a normal coagulation profile, again, APTT and PT-INR, despite being fully anticoagulated. It is imperative to know the time of the last administered dose, the creatinine and liver function test to determine residual drug effect prior to any attempted neuroaxial anesthesia or invasive spinal procedures for that matter. And included for your own review are some of the comments from the package insert. So a quick summary, these are the FDA-approved indications of the oral anticoagulants. So again, for VTE prophylaxis, specifically in orthopedic procedures, you have apixaban, rivaroxaban, and warfarin for knee and hip, and you have dabigatran included with that group when you extend it to hip arthroplasty. For VTE treatment and non-valvular AFib, you have all of these included, but then when you come down to mechanical heart valves, only warfarin is available as an option for an oral anticoagulant for these patients. So on the perioperative anticoagulation. So as the mechanisms of action and pharmacodynamics of the DOACs are completely different than warfarin, so too are our strategies for interrupting anticoagulation for surgery or dealing with bleeding complications. So we will review that depending on the clinical scenario, anticoagulation or antiplatelet medications may be continued, stopped, or replaced with a parenteral anticoagulant. We will review that the timing of interruption of these agents prior to surgery. We'll quickly review the resuming of anticoagulation after surgery, and we'll briefly discuss how to manage bleeding complications related to anticoagulation. So for perioperative management, there's 3 major steps. So first and foremost is the need to determine the timing and the need for the surgery. So what is the patient's planned duration of anticoagulation therapy? Is this a procedure that could wait until the patient is no longer on anticoagulation? Or can the surgery be deferred until their thromboembolic risk is decreased? The second step, if the patient must proceed with surgery at this time, what is their periprocedural thromboembolic risk? And again, we would want to consider venous thromboembolism, atrial fibrillation, or mechanical heart valves in this group. And our third step is to assess the periprocedural bleeding risk. So for our risk stratification, again, reaching back to some of our initial slides, those high-risk patients are the ones who've had VTE within the prior 3 months, a significant thrombophilia, such as protein C or S deficiency, antithrombin deficiency, or antiphospholipid antibody syndrome. While off anticoagulation, the risk of propagating an existing DVT or formation of a new DVT is high for these patients. There's a 50% recurrence rate within 3 months of a proximal leg DVT if off anticoagulation. There's a relative paucity of data in terms of short-term risk and periprocedural risk for many of these patients. And again, we've got the added transient thrombotic risk related to surgery itself. For patients who are moderate risk, this is a rather broad category, but these patients have an estimated 15% recurrence risk of VTE within 1 year if off anticoagulation for that year. Again, relatively limited data in terms of short-term risk and periprocedural risk and added transient thrombotic risk related to the surgery itself. Please note that if patients have multiples of these risk factors, so for example, if they have a prior history of VTE and they also have cancer, they may actually bump up from that moderate risk category to the high risk category. Please also note that included in here are those very common, less severe thrombophilias. The heterogeneous factor V Leiden, the heterogeneous prothrombin gene mutation. And additionally in here are patients who have not had a recent venous thromboembolic event but have had prior recurrent events, even in the absence of a known thrombophilia. Those patients who are overall considered fairly low risk are patients who've had a prior history of VTE more than a year ago. And these are patients who they still have increased risk compared to other patients who have not had prior VTE, but they're certainly lower risk than those who are in the high to moderate risk groups. These patients have already completed their course of anticoagulation, and their risk of recurrent VTE is low enough that they do not warrant long-term anticoagulation. So moving on to step 2, assessing our periprocedural bleeding risk. So this really has 2 pieces to it. The first is the actual procedural bleeding risk, and then the second piece is patient characteristics associated with increased bleeding risk. So regarding procedural bleeding risk, this is hugely dependent on the type of surgery, and it's important to note that although there's focus on intraoperative bleeding, actually 2/3 of bleeding events occur in the immediate postoperative period. So different professional societies have published recommended guidelines specific to their procedures. The 2017 ACC Expert Consensus document from the American College of Cardiology gives recommendations on perioperative anticoagulation for non-valvular AFib and uses the following categories. Again, the limitations of this is there's wide variety and heterogeneity between these procedures themselves. And admittedly, there's a lot of disagreement and recommendations for perioperative anticoagulation management between these different society guidelines. So especially when you look at commonly performed procedures such as hysterectomy, hip and knee replacements. Key points to remember are that surgical procedures involving highly vascularized organs such as kidney, liver, and most vascular or other cardiothoracic procedures, or those involving closed body compartments such as the intracranial and spinal space, are high risk because the potential for bleeding even a small volume in these spaces can lead to substantial morbidity or mortality. So when assessing patient risk, a comprehensive medical and bleeding history is essential in the assessment of your patient. Notable patient characteristics associated with increased bleeding risk include age greater than 55, prior stroke or known vascular disease, impaired creatinine clearance, hepatic dysfunction, congestive heart failure, anemia, cancer, hypotension, severe hypertension, blood pressure is greater than 200, female gender, diabetes, and prior history of bleeding. Several prediction models have been used to estimate bleeding risk for patients with atrial fibrillation and anticoagulation. These include the HAS-BLED and hemorrhages score. However, limitations of using the scores include that they're specific to those patients with atrial fibrillation. We certainly, quote-unquote, borrow from their data for patients who are anticoagulated for other indications, such as VTE. However, these were initially validated in patients with AFib. And frankly, this data all reaches back to patients who were essentially anticoagulated with warfarin. We've got a relative kind of paucity of data in terms of the DOACs that are available. So it's unclear how generalizable these are to other patients. And just another note, please be aware, again, of other agents which impact hemostasis but do not affect the coagulation profile. So that includes the antiplatelet agents, the low molecular weight heparins, and fondaparinux, which is a heparin-like product, and then vitamins and herbal supplements, which seem to be ever increasing in popularity. So a quick summary. For the interruption of warfarin, for a patient with a history of prior DVT or PE, if it's a remote history, bridging is required for a known high-risk thrombophilia. If it's a recent DVT or PE, again, recommend bridging. Depending on the clinical scenario, you may need to consider a temporary IVC filter placement. I would definitely recommend expert consultation for a patient with a known high-risk thrombophilia or with recent DVT PE. And in general, with warfarin, we're holding this 5 days or 5 doses before surgery. For atrial fibrillation, the need for bridging is dependent on the thromboembolic risk. So again, please reference those prior slides on the CHAD-VAS score for risk assessment. Same with VTE, we hold for 5 days. For mechanical heart valves, the recommendations can be very, very patient-specific. So here's a list of the general bridging recommendations or kind of suggestions from some of the expert societies here. Often warfarin stopped 2 to 4 days prior to the procedure if aiming for a target INR of less than 1.5 on the day of surgery. When the INR is less than 2.0, it's recommended to start bridging anticoagulation with unfractionated heparin or enoxaparin. Generally, it's to start about 48 hours before surgery for those patients who are moderate to high risk. For post-procedural management, warfarin should be restarted as soon as possible after the procedure, as soon as the bleeding risk allows. Usually this is later the same day or on postoperative day number 1. And then heparin or, and not listed on the slide, but heparin or a low molecular weight heparin, such as enoxaparin, is continued until the INR is within the therapeutic range. So whether that patient's target is 2.0 to 3.0 or 2.5 to 3.5, it's important to make sure the INR is really fully elevated to that range before the parenteral anticoagulant is stopped. Going back briefly, the timing of stopping anticoagulation before surgery for the parenteral agents is a little bit proceduralist and surgery specific. Typically, unfractionated heparin is stopped 4 to 6 hours, more typically 6 hours before surgery. This may be variable for cardiothoracic or vascular procedures if they're anticipating use of unfractionated heparin in the OR. And additionally, the last dose of enoxaparin, if using low molecular weight heparin, should be 24 hours before surgery. So the morning, the day prior to surgery, not the day of surgery. So, and just a quick visual for you. So pharmacokinetics are everything when it comes to thinking about warfarin versus a DOAC. Because the timing of anticoagulant interruption is completely dependent on pharmacokinetics and renal function. So always remember, warfarin has a relatively slow onset of action and a long half-life. the DOACs generally have a fast onset of action and a short half-life. For most of the parenteral anticoagulants, they're often more like the light switch model. They have a fast onset of action and generally a short half-life. The one exception to that, as we'll see in a later slide, is actually fondaparinux, which has a very long half-life and as a result is not ever appropriate for bridging for these patients. So this is a summary slide that reviews timing of interruption of DOACs prior to procedure. As I mentioned, this is highly dependent on renal function for these patients. So I have this chart broken down as such. In general, we want to look at whether our procedure is a high bleeding risk or a low bleeding risk procedure, and that's also going to help to determine when our anticoagulant should be held. On quick overview of this table, you will see that often the DOACs are only held for 2 or 3 days before a procedure. The major notable exception to this is for dabigatran, and this is specifically for patients who have renal impairment. These patients may need to be off of their anticoagulation for 4 to 5 days to allow adequate washout of the drug because of the half-life prolongation in renal dysfunction. Similarly, if you were to have a patient arrive to your service and have them arrive in acute kidney injury with very poor renal function while they were still taking their DOAC, it would be imperative to have them hold this for an adequate amount of time to wash out. But in general, as you look down at rivaroxaban, apixaban, and edoxaban, each of these for high bleeding risk procedure, these patients will generally take their last dose 3 days before the procedure. So they do not take the doses on preoperative day -2 and -1. And then for low bleeding risk procedures, they will often take their last doses 2 days before the procedure. So they're only holding their doses on preoperative day -1. Additionally, and for this I would generally recommend expert opinion and consultation. If patients arrive to the hospital who have severe renal dysfunction and are on these agents, it may be reasonable to check an anti-10A assay to try to determine residual drug effect before undergoing invasive procedures. But again, please consult with your local vascular expert or hematologist for assistance with this. So resuming anticoagulation after surgery. As a vascular medicine consultant, this is where I often rely on my surgical colleague to help me and to get input from them about how they feel the bleeding risk is for the patient. So the easiest statement is to say resume when the risk of surgical site bleeding is felt to be decreased. It's generally better to wait and avoid a bleeding complication than to have a complication and then need to wait weeks before resuming anticoagulation. Certainly consider prophylactic intensity anticoagulation while the patient is off therapeutic anticoagulation, and I have the doses listed there for you to review. Always update your labs before reintroducing anticoagulation to ensure that blood counts are stable, to ensure that the patient has not developed renal dysfunction, that the albumin is within acceptable ranges, and that the patient hasn't developed any other coagulopathy related to nutritional deficits or any other derangements like DIC. If you're concerned about initial bleeding risk, consider an initial trial with an anticoagulant that has a shorter half-life and reversibility, such as unfractionated heparin or even enoxaparin, which can be more easily reversed with protamine than needing to use blood products to reverse the DOACs. Other factors to consider for your patient, certainly if they have poor oral intake or ileus or they're planned to have multiple stage procedures, you may want to temporarily defer their resumption of anticoagulation if they're deemed to be low enough risk for thrombosis. This again is an overview table that's built out to look at number of days to hold anticoagulation pre-procedurally, and then additionally kind of general guidelines for when to resume. Generally, it's recommended that the DOACs can be resumed 2 to 3 days after surgery for a high bleeding risk procedure and as quickly as 24 hours after a low bleeding risk procedure. But again, please use your judgment in assessing your patient's bleeding risk. So a quick overview about periprocedural antiplatelet management, because this does differ from anticoagulation management. We'll quickly touch on aspirin dosing and dual antiplatelet dosing, including aspirin for primary and secondary prevention, and then how to stratify your patients who are on dual antiplatelet from high risk to low to moderate risk. So, quick review. Aspirin is an irreversible inhibitor of platelet activation, which in turn decreases platelet function and increases bleeding risk. A platelet lifespan is 7 to 10 days. So that's where we come up with this 7 days to hold aspirin before surgery. It takes that long to turn over the platelets and to replace the platelets that have been inhibited. The most common use of aspirin is actually for primary prevention of cardiovascular events. And this is per the United States Preventive Services Task Force recommendations for men and women who, in the absence of high risk for GI bleeding, it is recommended that they take aspirin 81 milligrams once a day. Compared to patients on aspirin for secondary prevention, these patients have a lower risk for ischemic cardiac events, and they can simply stop their aspirin 7 to 10 days before surgery to minimize their bleeding risk. Regardless of the bleeding risk inherent with the procedure they're having, they can stop. Aspirin for secondary prevention is a little bit more complicated. So secondary prevention is essentially for management of your patient with known cardiovascular disease. So discontinuation of aspirin in these patients is associated with increased risk for MI and stroke within the 1 to 2 weeks postoperatively. And they need a good bleeding risk stratification to determine which of these patients can continue their aspirin perioperatively. So if they have a low bleeding risk procedure, it's generally advised to continue aspirin. If they have a moderate bleeding risk procedure, it's been found that there's no increase in mortality related to bleeding if aspirin is continued, but there is a reduction in MACE, so major adverse cardiovascular events. And generally, the benefit of continuing aspirin outweighs the risks. However, you should advise these patients that they do have increased possibility for need for blood transfusion. If they're undergoing a high bleeding risk procedure, they should stop aspirin 7 days before the procedure and then resume promptly when the bleeding risk is sufficiently low. So management is somewhat different for your patient on dual antiplatelet therapy, or DAPT. So usually dual antiplatelet therapy consists of aspirin plus an ADP receptor inhibitor. So these include clopidogrel, prasugrel, ticagrelor. With use of these agents, especially in combination with aspirin, there's near complete loss of platelet function, but platelet count will remain normal. And I think that's the deceptive thing. These patients will have a normal platelet count on their blood counts. However, the platelet function has been eliminated. There's an 8-fold increase in bleeding risk for patients on DAPT versus on aspirin alone for patients undergoing intermediate bleeding risk procedures. Specifically, for patients on DAPT, you need to watch out for the high-risk patients. These are the patients who have just undergone percutaneous transluminal coronary angioplasty within the prior 2 weeks, patients who've had myocardial infarction less than 6 weeks ago, a bare metal stent less than 6 weeks ago, a drug-eluting stent less than 6 weeks ago, or a high-risk drug-eluting stent such as after a STEMI within the last year. These are your high-risk group. These high-risk patients are extremely high risk for MACE, again, major adverse cardiovascular events, in the perioperative setting, which include heart attack, in-stent thrombosis, and sudden cardiac death. So first and foremost, the questions you should ask yourself are, can this surgery be delayed until the patient is off DAPT? Or can the surgery be done while on DAPT? And please note for these patients, platelet transfusion does not reverse the effects of ADP receptor inhibitors. So for your high-risk patients, if they're having a low bleeding risk surgery, continue DAPT until the day before surgery, and then resume immediately after the procedure, presuming that no major bleeding has occurred. For your patient undergoing a high bleeding risk surgery, we suggest this strategy. Stop aspirin 7 days before the procedure and stop the ADP receptor inhibitor 5 days prior to surgery. We recommend bridging, but with use of a short-acting parenteral antiplatelet agent. so not heparin, but specifically a short-acting parenteral antiplatelet agent. These are the glycoprotein 2B3A inhibitors. This infusion is generally started 24 hours after the last oral dose of the ADP receptor inhibitor at home, and then the infusion is held for hours before surgery. And this varies depending on the agent. This can be anywhere from 3 to 12 hours before surgery that the agent is stopped. DAPT should be restarted immediately after surgery, either using that parenteral agent plus aspirin again, or the oral agent plus aspirin. The trickiest patients are those who kind of fall into this moderate bleeding risk surgery group. This is kind of a gray zone. So it's suggested to either stratify your patient to one of the strategies above, either the low or the high bleeding risk group, or to continue aspirin throughout the time period of their surgery while holding the ADP receptor inhibitor for 5 days prior to surgery, with reinitiation promptly after surgery, including a loading dose at that time. With any of these patients, due to the fact that they are high cardiovascular risk, it's always reasonable to seek expert consultation and to have their cardiologist weigh in on their care. For your low to moderate risk patient on DAPT, these are individuals who are still having relatively high risk for perioperative MACE as compared to the baseline population. And generally, it is still recommended to try to limit the amount of time that they have off DAPT. So typical recommendations include stopping the ADP receptor inhibitor 5 days before surgery, continuing aspirin through the perioperative period, and then restarting the ADP inhibitor as soon as possible after surgery, either with or without a loading dose, depending on the patient's circumstances and the bleeding risk. So general recommendations to take away from this: low bleeding risk procedures, anticoagulant and antiplatelet therapy can be often continued peri and postoperatively. Moderate to high bleeding risk procedures, oral anticoagulants are most often interrupted with short-term parenteral therapy in select patients. For moderate bleeding risk, this is dependent on the proceduralist preference and type of procedure. Some moderate risk surgeries can be done while on antiplatelet therapy. And then for high bleeding risk procedures, antiplatelet therapy is generally held or interrupted. So for bleeding on anticoagulation, there's two assessments of bleeding, and that's minor versus major bleeding, and management strategies that follow each. So reverse strategies for warfarin. This is largely dependent on INR level and bleeding. So for a patient who has serious or life-threatening bleeding at any INR elevation, there's actually expert guideline consensus here from two different professional societies that both recommend utilization of a 4-factor PCC, utilization of IV vitamin K, and of course holding warfarin. For patients who have either no bleeding or minor bleeding, epistaxis or something that's easily controlled with local means, but the INR is greater than 10, the 2012 ACCP guidelines recommend administration of oral vitamin K. The American Society of Hematology, the ASH guidelines, do not give specific recommendations. Similarly, for bleeding that is not present or minimal at an INR elevation of 4.5 to 10, it's recommended that potentially a small dose of oral vitamin K be considered, but not mandatory, and additionally to hold warfarin while the INR is dropping. So in all of these cases, you're kind of weighing the benefit of reversing your vitamin K antagonist or your warfarin against the potential risk of thromboembolic events. And it's important to note that when using these 4-factor PCCs, that fatal and non-fatal arterial and venous thromboembolic complications have been reported, both during the clinical trials and post-marketing surveillance. And specifically, PCCs were not studied in patients who had ever had a prior thromboembolic event or myocardial infarction, DIC, stroke, TIA, unstable angina, or severe peripheral vascular disease within the prior 3 months. So a few notes on these specific products. So vitamin K as I was alluding to, is used in the setting of life-threatening bleeding and urgent reversal. The dosing for this is generally vitamin K 10 milligrams IV, given by a slow infusion. Giving the slow infusion over 20 to 60 minutes helps reduce the risk of having a reaction. The vitamin K can be repeated at 12-hour intervals if the INR does remain elevated. If the INR remains prolonged after repeat dosing, look for additional causes of INR elevation. Is it actually DIC and hepatic dysfunction or some other underlying issue driving this? I generally recommend avoiding subcutaneous vitamin K because absorption is inconsistent, so your therapeutic effect is very inconsistent, and yet there are still risks of adverse reactions. And then please note, because I feel this is often underutilized, but oral vitamin K dosing provides equivalent but slower INR reversal than IV infusion. So again, going back to those previous recommendations, for the patient who has maybe that significantly elevated INR of more than 10 but is not bleeding, your oral vitamin K is a very reasonable option. So the prothrombin complex concentrates, or PCCs, these must be administered concurrently with a dose of vitamin K. And the reason for that is if you do not administer vitamin K at the same time, you will end up having an INR rebound as the half-life of these administered coagulation factors wears off, because the half-life of warfarin is actually longer than that of the coagulation factors in this concentrate. So guidelines generally suggest a 4-factor PCC for rapid reversal of anticoagulation in the setting of serious bleeding with an INR more than 2. And currently this is recommended over use of fresh frozen plasma. And part of this reason is that FFP must be thawed, and it's generally a large volume that has to be administered. And oftentimes an unstable patient may not tolerate this large volume. The unactivated 4-factor PCCs include the brand name product Kcentra. This includes factor 2, factor 7, factor 9, and factor 10 in inactive forms. There is also a 3-factor form which contains little to no factor 7. This is important to note. And this is actually a product that is used off-label for INR reversal. And then your activated 4-factor PCC, the brand name of this product is FIBA. The difference is that all of these factors are largely activated, and it's an off-label use for use of this product for INR reversal. So for our DOACs, as we mentioned on a prior slide, for dabigatran, dabigatran does have a specific monoclonal antibody for reversal. However, that really should be reserved for major bleeding. So for minor bleeding, for all of these agents, we recommend local hemostatic measures, considering discontinuation of the anticoagulant, and then possible antifibrinolytic agents. So tranexamic acid is a great example of this. The half-life of dabigatran is 12 to 17 hours. The half-life of rivaroxaban is 5 to 9. Apixaban is 8 to 15 hours, and edoxaban is 6 to 11 hours. So oftentimes for kind of minor bleeding such as epistaxis or soft tissue bleeding or slow GI ooze, interruption in the DOAC therapy and local measures is often pretty sufficient. For more major bleeding, as I was alluding to, use of idarucizumab, or Praxbind is the brand name for dabigatran's reversal agent, is absolutely reasonable to consider. If the patient has just recently taken their last dose within the last 2 hours, oral activated charcoal is recommended for all of these agents. For dabigatran, additionally, there are case reports of off-label use of FIBA. Certainly antifibrinolytic agents can again be used in the setting of major bleeding, but they're less effective. Hemodialysis, again, with those specific dialysis membranes. Certainly RBC transfusions for support for their anemia, and platelet transfusions for platelet impaired function due to oftentimes concurrent aspirin administration. And then, of course, surgical IR endoscopic intervention for bleeding source control. Many of these factors are similar for the other DOACs, for the anti-10A factors. The main difference being the kind of very specific reversal agents. So andexanet alpha, or Andexa, is the reversal agent that is now available for rivaroxaban, and reportedly this is a universal reversal agent for all anticoagulants that work through factor 10A. However, the major issue with andexanet alpha is that it is not yet widely available. Hopefully this will change in the near future. Additionally, 4-factor unactivated PCC, again, that Kcentra has been used off-label with varying degrees of success for control of bleeding for patients who have bleeding on the anti-10A agents. And again, fortunately, the half-life of these agents is shorter relative to warfarin, so the effect does wear off somewhat more quickly. However, be mindful of your patients who have significant renal or hepatic impairment, that the wearing off of effect may be delayed in these patients. So, and then just one slide quickly on parenteral anticoagulants, because an in-depth review or a deep dive of these products would be beyond the scope of this talk. But this just gives you a quick reminder of your different routes of administration, your half-life, and the time periods to interrupt these anticoagulants before surgery, as well as their reversal agents. So fractionated heparin is the one that I would say physicians are most familiar with. Most typically we're thinking about this in the context of IV administration, but there certainly are other routes that we administer it. The half-life is very dose-dependent and route-dependent, but it ranges from 30 to 150 minutes. Generally, we're holding this 6 hours before procedures, and notably, our urgent reversal agent is protamine sulfate. That's the key thing to remember with this. Bivalirudin is an additional parenteral anticoagulant. This is a direct thrombin inhibitor. This has a very short half-life. It is administered IV with a half-life of only 25 minutes. Generally, it is held 2 hours before an invasive procedure or 6 hours if severe renal impairment or very significant concern for bleeding risk. There is no urgent reversal agent. However, again, the short half-life does give a little bit more control over this agent. Argatroban is an additional IV direct thrombin inhibitor. This has a longer half-life than bivalirudin at 39 to 51 minutes, and notably in the setting of significant hepatic impairment, this half-life dramatically increases to 181 minutes. This agent must be held at least 3 hours before, and there is no specific reversal agent in the setting of bleeding. Enoxaparin is the best-known low molecular weight heparin in the United States. This is administered subcutaneously. The half-life on average is 4.5 to 7 hours. The last injection before surgery should be 24 hours before surgery. Off-label use of protamine provides 60 to 75% neutralization of the anti-10A effect of enoxaparin. Deltaparin and fondaparinux are two additional injectable low molecular weight heparins, or fondaparinux is technically a heparinoid or a heparin-like product. The notable difference with these is that dalteparin, again, has a short half-life of only 2 to 8 hours. Fondaparinux, or brand name Arixtra, is the one that has the very long half-life of 17 to 21 hours. It is a once-a-day injection. However, it is not appropriate for use of bridging prior to surgery, and I would be hesitant for use after surgery due to that long half-life and non-reversibility. So I would use this medication with care. Generally, the last injection of fondaparinux has to be 3 to 4 days before surgery due to this long half-life. And going back to our protamine reversal medication, please recall that protamine dosage is dependent on the duration of time since the heparin administration. So usual dosing for heparin that was very immediately administered is 1 to 1.5 milligrams of protamine per 100 units of heparin. However, the protamine is usually given in kind of predetermined dose aliquots of 25 or 50 milligrams. This is given slowly as the IV infusion. And then there's a continuous infusion usually given over 8 to 16 hours if the patient had had extensive heparin exposure requiring neutralization. If it's been 30 to 60 minutes since the last heparin administration, protamine dose actually reduces to 0.5 to 0.75 milligrams per 100 units of heparin. And if it's been already more than 2 hours since the last administration of heparin, the protamine dose reduces even further to 0.25 to 0.375 per 100 units of heparin. And again, I recommend expert consultation if there's any questions about this, because some of this is beyond the scope of this talk. So, in summary of this very extensive review, venous thromboembolism is a common and preventable complication of hospitalization and surgery. Few patients may have a diagnosed severe thrombophilia, but many will have acquired or situational hypercoagulability. And especially, please always remember that the perioperative patient, particularly those who have had prior venous thromboembolism, who have mechanical heart valves or have atrial fibrillation, these are all individuals who are at increased risk for thrombosis, particularly in the postoperative setting. Please be aware of patients with high-risk mechanical heart valves or high-risk features for stroke associated with AFib. Anticoagulation use is on the rise, especially since the advent of the DOACs, due to ease of administration and lack of need for routine lab monitoring. But be aware that these anticoagulant and antiplatelet agents that decrease hemostasis do so without changing the PT-INR or the APTT. Interruption, resumption, and management of bleeding complications is different for patients on DOACs as compared to warfarin, and this has been a major shift in how we have to think about management of these patients. So I thank you for your time.